title of my talk, Blanketing the World with Self-Help Automated Internet Interventions, Contributing to Making Healthcare a Universal Human Right. And I'll feel I've succeeded if sometime after this conference you still remember that metaphor of blanketing the world. Little baby blankets around the world for different health problems. Okay? See if you can remember that. Okay, the key points. First, healthcare as a universal human right has been an aspiration for many years for humanity. I think now we have the potential to actually share evidence-based health interventions with people worldwide. And to actualize this potential, I have divided my talk into three parts. A conceptual framework I want to share with you, a visual aid, actually a couple of visual aids, and some data-based proof of concept evidence. I'll finish up with a call to action. In December of 1948, the United Nations proclaimed the Universal Declaration of Human Rights. Article 25 stated that everyone has the right to medical care and necessary social services. And the following article also said that everyone has the right to free education that should be directed to the full development of the human potential. I think both of these articles are relevant to our work. Now, early on I realized the limitations of current methods of delivering evidence-based healthcare. For example, evidence-based cognitive therapy for depression was tested in randomized controlled trials in the format of 20 individual hours of cognitive therapy. So one therapist working 40 hours a week and seeing a patient every hour would see the equivalent of 2 patients per week. If that therapist worked for 50 weeks a year, that therapist would be able to see a maximum of 100 patients per year. Now, obviously, that is not enough to take care of all the people who have depression, let alone any of the other disorders that we have to deal with. So in 1978, Andy Christensen, Bill Miller, and I published a paper in which we laid out a framework for expanding mental health service delivery. We basically argued that the healthcare system focused primarily on one box, the green box there on top, which focuses on treatment by professionals. We argued that in order to reduce prevalence of mental disorders and other disorders for that matter, you needed to go beyond treatment. You needed to do prevention and you needed to do maintenance. We know, for example, that substance abusers relapse often. The same thing is true for obesity, depression, a number of other disorders. So you needed to focus not just on treatment of the acute episode, but also preventing and maintaining progress. But if we were giving inadequate levels of treatment to the populations where we worked, how could we increase our work to prevention and maintenance? So we recommended, we presented this framework, that we needed to go beyond treatment by professionals. And we needed to use systematically paraprofessionals, that is, people trained to do specific interventions and paid, of course, for their time. Partners whom we defined as volunteers in a helping role. Peers, people who helped other people facing similar situations, such as Alcoholics Anonymous, probably the most well-known example. All 4 of these, the first 4, involve face-to-face care of some type. Okay? And thus, these are consumable. At the end of the hour of intervention, that hour is spent forever. No one else can ever benefit from that hour. So that's an issue, a limitation of using even paraprofessionals, partners, and peers. We also talked about paraphernalia, I'll talk about that in a second, and print, the use of self-help books and other materials that are printed. I'm going to focus here on paraphernalia, by which we meant electronic devices, radio, television, audio-video recorders, step counters, wrist counters, etc. In 1978, there were no personal computers yet. That came up in 1982, and the web, of course, started in December of 1990. So, but we did talk about using what we called then learning machines. These were computers that actually were programmed to teaching machines. And of course, now we are developing work with the internet. I think that a way of contributing toward making healthcare a universal human right is to use the internet, e-health, and m-health interventions to provide a basic level of care, upon which more expensive healthcare practices can be built. I'm a director of a clinical psychologist training program. I train therapists, one of whom is here, Stephen Schuler, who will be presenting tomorrow. So I'm training therapists. I really believe in doing face-to-face treatment. I just think it's not enough to do that. I wish I could train enough therapists to provide individual treatment for every person in the world who needs it. Heck, for every person at San Francisco General Hospital, where I work, who needs it. I've been working there for 34 years, we still don't have enough therapists trained. So this quote I found helpful. It's the greatest of all mistakes to do nothing, because you can do only a little. Do what you can. So I am training therapists to do this kind of care, but I'm also trying to develop internet interventions to help the people that I cannot train therapists to help. Let's move to the visual aid. How might we blanket the world with evidence-based internet intervention? This pentagon represents face-to-face traditional services. In other words, should be a clinic or a community mental health center where there would be providers, professionals, paraprofessionals, partners, peers perhaps. These days you can also do live telehealth interventions. David Moore's work on phone therapy for the depression, for example, is a great example. Randomized controlled trials showing that that is effective. There are also chat rooms, instant messaging, a lot of ways in which you can do guided help. But the problem with this is that if you think of the horizontal here as a territory, a region, there are places where there are clinics and community mental health centers and so on, but there are a lot of gaps where the people are not able to get help. Self-help, automated, evidence-based internet interventions can actually provide a blanket that goes through the entire territory, all of the continent here, for example. It's possible to actually blanket the entire territory. Now you can do this and still interact with face-to-face and live services, or with guided adjuncts, email, phone, SMS, and so on. You can do this, and you can, of course, combine all three. So you're not taking anything away from people by providing these internet interventions. You are actually closing the gaps where there are no services, where there are no people who speak the patient's language, for example, where there are no trained cognitive behavioral therapists. Now, if we try to do this, we need to create some standards for evidence-based internet interventions. For example, accessibility for people who cannot read by providing audio and video sections of the internet site, for example. Programming hooks that allow the user seamless input and output under the user's control for privacy and security. Input and output of information using mobile devices, SMS, for example, text messaging, that would enter number of cigarettes smoked in a certain day, for example, onto the website. Social networking groups, guided intervention personnel, for example, quit lines for smoking cessation, where the person using the internet stop smoking site would be able to provide access to a coach through the phone, for example. Personal health records and electronic medical records, and ideally combining all of these together. This also would create collaborative research capabilities. If we were able to develop standard cores of demographic and key health measures that we all would use. And we could jointly create massive databases which could then be mined to explore predictors of risk and of responsiveness to behavioral, pharmacological, and other interventions in international populations rather than in geographically limited populations, which is what most of the work that we do entails now. We could even go further into developing reliable phenotypic information on our users that could guide genetic association studies. So we could combine a work with another area that's growing very fast these days. So these interventions would be used where no interventions are available. I do not want to replace current interventions, but to provide them where no interventions are available, while patients are on waiting lists, during treatment, as an adjunct, after treatment, to prevent relapse or recurrence, for patients who cannot travel to clinics, for patients who fear stigma or whose providers do not speak their language. And then again, we could expand beyond treatment into prevention and maintenance. So now some data, proof of concept. In 1997, we wrote our first grant to do an internet intervention. We got it in 1998. It's the San Francisco Internet Stop Smoking site. Note on the bottom here in the resources, there's a link to our smoking cessation guide. So everybody who visits the site can immediately download a evidence-based NCI, National Cancer Institute approved Stop Smoking brochure. So you don't have to actually sign up to obtain an active ingredient of the intervention. Now, when we began, we got this money from the Tobacco-Related Disease Research Program, which is a California group that gets money from the tobacco settlement in the US. And so we were focusing on California smokers, Spanish and English-speaking smokers in California. And most of the people we got at first were from the US. But as years went by, what you saw is that we were starting to get people coming from all over the country and actually from all over the world. The countries listed here are the countries that have over 1,000 people who have come to our site. And some countries have been using our site at very, very high rates. So this is, again, another visual image of blanketing the world. There are countries here like India, for example, or Malaysia or Pakistan that we have no contact with, really, except through our site. But there are literally thousands of people coming to our site and using them. Now, these are the cumulative numbers. You see that Spain has had over 100,000 people come to our site. Argentina, over 40,000 people. Mexico and the US, over 20,000 people each. You get to Pakistan, only 1,000 or more people. But still, it's an amazing number of people who can use this. Let's look at our two biggest English-speaking customers, the US and India. When we began, the US was our major customer, and India had basically nobody coming to our site. I want you to just pay attention to what happens on a year-by-year basis here. This year, we got a Google grants, Google Ad grant, which allows us to put up Google ads. And so we got a lot more people from the US, but not many from India yet. But then as the years go by, you can see that India begins to grow until in 2009 it actually has more people than US people, and in 2010 it grows by a large margin. It's an almost exponential curve there. I don't know where it'll reach, but it's amazing how many people you can reach through the web. Now, ideally, international health organizations would take this on as a major initiative. I mean, if this is an evidence-based intervention that can provide smoking cessation rates that are comparable to those of the nicotine patch, for example, which is what we have found, it should be taken over by international organizations. But it's hard to budge bureaucracies. The benefit of current technology is that a small team, and in the last 2 years, it's been myself and a half-time research assistant who've been monitoring the site, basically, and of course we pay for hosting the site at the university. A very small team can actually host this and keep it running and serving a large number of people. In a distributed process similar to the internet, many teams led by people like ourselves could in fact develop interventions for many health problems and help to blanket the world with them. Now, how would they reach them? Well, Beacon is obviously the place where many people would be able to find the sites that have evidence for their efficacy. And I think we should all try to support Beacon in doing that. So the call to action is that healthcare researchers, I believe, should systematically develop, test, and widely disseminate evidence-based internet interventions. And this basic level of healthcare should be made available freely to all persons worldwide in order to blanket the world with life-enhancing and life-saving interventions. We have begun developing interventions to prevent postpartum depression using cognitive behavioral approaches in Spanish and English. We're developing a depression prevention and management site too. And of course, in 2011, paraphernalia has to include mobile devices. So we recently launched a Stop Smoking iPhone app, which is on the iTunes store right now, using some of the same ideas from our internet site. We're developing a mood app and a pain app, and we hope to move to the Android as well. And I wanted to kind of stop for a second here and say, the way we got going on this was trying to think outside the box of treatment by professionals, right? But of course, when you think outside the box, what you do is you create a bigger box. And then what you have to do is think outside that box too. I mean, all I've talked about here, and most of what we've talked about here today, is self-change interventions, individually focused behavioral change. We need to go beyond that too, I think. We need to talk about changing social environments. For example, in California, the smoking rate has dropped tremendously, but not because of the efficacy of smoking cessation efforts. It's been because of laws passed, creating no smoking ordinances throughout cities and so on. We need to be thinking of internet interventions to help other communities to develop such ordinances, for example. The same thing true is for obesity, social networks and so on. Before ending, I just wanted to mention some of our funders and my colleagues who've worked with me over the years, and leave you with another visual aid here, the idea of blanketing our beautiful globe with interventions that can reduce human suffering. Thank you.